Hello, everyone, and welcome to Welcome Change, an Ashoka series on meeting social entrepreneurs and learning about what they're doing, what's working, what's not, and the role that we can play in systems change and in social change. My name is Yeleka Barrett. I am a change leader here at Ashoka, focused on the work of health. And I'm immensely excited to be joined today by our guest, Ashoka Fellow Isabelle Kamariza. Welcome, Isabelle.
Yes, thank you, Yeleka. I'm happy to be here and really excited.
So excited to get into this conversation. We do have a few housekeeping points, so I want to get to that quickly. This is a very short conversation, 30 minutes. I have a ton of questions for you, but I'm going to try and get them into about a 20-minute mark and then leave some room open for participants to ask their questions. We are live on Zoom, but this will be recorded and put up on YouTube, so we're very excited. So participants, get your questions ready as we dive right in. But again, welcome, Isabelle, the founder of Solid Africa, a social enterprise focused on nutrient security in the healthcare system in Rwanda. To date, you have served over 7 million meals since 2010 when you were founded. And so I want to discuss everything from food to healthcare to loving meals. So let's dive right in. And let's start with the topic of nutrition as a link to healthcare and health access, or a missing link to healthcare and health access. One of the learnings that we have within Ashoka is that we see society shifting from a paradigm where healthcare is equal to sick care to a paradigm where we understand the holistic approach to wellness, to illness prevention, and to adherence to healthcare interventions. And Solid Africa is a holistic approach to that. Can you walk us through your journey to creating Solid Africa? Walk us through when you realized that nutrient access was a key missing link in being able to provide healthcare, sufficient healthcare to patients in Rwanda.
Yes, thank you so much, Yeleka. And yes, we love to say that we work really in nutrition security and not food security. Because when people talk about food, they're always concerned about, but are people food are secure? Are people food secure? So our aim is that you can have food, but it doesn't mean that actually you have nutrients and you have nutritious meals. And globally, already in the world, you have 3 billion people that can't afford to have access to a healthy meal. So this is like an issue that is everywhere. And if you talk about that, then we are talking about the health of people. How can we become healthy citizens to be able to be active in the society if we are not healthy ourselves? So our work started, yes, in Rwanda, in Kigali, in hospital in 2010. I met an amazing woman in a prayer group, and I was just coming from university, coming home back to Rwanda, and she told me, there are patients in hospitals that don't have families because here in Rwanda, food is not part of the hospital stay. So, and Rwanda is one of the few countries that actually have universal health access, but you find that food is not part of it. So if you don't have a friend or a family or somebody to come and give you food on a daily basis, then it becomes difficult and challenging to be able to have access to nutritious meals. So when we started, or actually I would tell, like when we started, it was about food security. So we started with saying like, we would take 5 patients who don't have a family, who are coming from far, and we give them 1 meal a day. But soon, one of our first patients, she had chronic diseases, she had diabetes. So all the food we'll be bringing to her, she would say, I can't eat it. And if I eat it, because it's salty, this will increase. Because it's oily, this will do that. So that's the first time we started thinking about medically tailored meals and about nutrition security. And when we started, we thought, as you said, we are shifting paradigm. People are thinking holistically. So we thought it would be an easy way for people to understand what we were doing, but found out that it wasn't that. Because when people were talking about healthcare and health strengthening systems, it's always about what do the doctors need, the nurses, community workers, everything that they need, from drugs to equipment to infrastructure to apps, whatever you can think of that they need to cure people. And of course it's needed, but they were almost nobody that was thinking, what do patients need to be healed? And for us, it's like they need to take a shower, they need soap, they need food, they need clean water. And we took now the biggest challenge, which was food. So now what we do, so we started with 5 patients as a movement. When we started, we were just young people, most of them out of college, in our mid-20s, some of them with their first job. But for us, Solid Africa is really more than an organization. It is a movement of saying, we are, whatever you are seeing in your society that it doesn't work, if you come together, there's a way to solve it. And most of us had studied, went to university, so we were bright kids, but without money. But we thought, our brain can actually achieve this, and we can actually find the funds to be able to do so. So for the first 6 years, we were auto-financed by ourselves. What I'm saying is that we'll be selling T-shirts, we would be going everywhere. People would bring food from their fridge. That's how we organize it. People bring their own cars. And we did that for 6 years. And in those 6 years, what we wanted was to build an industrial kitchen, because that was, for us, the way to be able to do those medically tailored meals. So we cooked up in our homes up until 400 patients. And then in 2018, we had the great opportunity of actually pitching our idea to Imbuto Foundation, which is our First Lady Foundation here in Rwanda. And she gave us the support in partnership with the King of Morocco Foundation. She gave us the funds to be able to build the kitchen and equip it. So now what we do is that we do a farm to fork approach. So we are feeding 1,500 patients on a daily basis with 3 meals a day. And we do that by farming ourselves. We farm 84% of all the produce that we give. And then after that, we have the biggest industrial kitchen in Rwanda. We can produce 10,000 meals with only 10 cooks because on how it was designed and because it's semi-automated. In that kitchen, we do cater for around 8 diets. So we do medically tailored meals. We make sure that whatever the illness you have, we're gonna give you food that is appropriate to your illness for you to recover better. And as of now, we have, I would say maybe talk about 2 or 3. One of my favorite one is the breastfeeding mothers diet. So we make sure for the new moms that instead of just feeding them 3 times a day, we put flask hot beverages in between meals so that they actually can have 5 to 6 meals. And you find out, why is it my favorite? Because in 1 to 2 days, you can see a mother that was struggling with breast milk to actually have breast milk. And we do more than that, of course. We do liquid one for people that are too fed. We do one that is high protein, especially for people with cancer or somebody that have to go through dialysis. And then after that, we dispatch them in the different hospitals, and we take all the waste and we make our own fertilizer. We are also self-sufficient in our own fertilizer by 70%. So when we talk about nutritious food and the nutrient in our food, it's also that you have to link it to the farm, because you have to make sure I can give you 2 different tomatoes, but it doesn't mean that they have all the same nutrient. So one of the things also, it's that is seeing what is in our meals and what can it really provide to the patient. And what we are doing, it's not that our really big belief is that food is medicine. It's not even a belief, I think it's a fact. Food is medicine. And actually there are compelling studies that medically tailored meals actually do accelerate the recovery rate by 37%. And also do that you will have raised readmission rate at 42%. And that study was done with people with chronic diseases. So we don't have to prove that food is medicine. We don't have to prove that food should be part of the hospital stay. But you find that in countries, some countries in Africa, food is not part of it. You find that even the countries, especially in the public, you find that even in public hospitals where food is part of the hospital stay, is not actually great food, it's not medically tailored meals, it's just food, as we're talking, food security, to say that we have given you food you have eaten. But also when you go outside, when you go to the US, when you go to the Westerners, they're having a whole crisis when it comes to food in hospitals, because food is so salty, processed. And I talked to somebody one day who said, I would even prefer to have food from home because the food here doesn't work. So there's also a big movement, especially in the US, with the food is medicine, where they're trying actually to change policies and to have food, healthy food, medically tailored meals, food that are prescribed as a prescription, so that it's part of the insurance. Some states have succeeded, some are starting. And for us, what we want is to leapfrog, not to wait, and to actually give our patients healthy meals.
Amazing journey. There's so many things to touch on there. Thank you for sharing. I definitely want to come back to the farm to fork approach, and deep dive into that a little bit. But before we go there, you touched on a few pieces of like moving and mindset shift from food security to nutrient security, because sometimes you can have food, but it's not actually supporting your healthcare journey, and supporting the patients. And then you touched on the fact that, you know, universal healthcare access is available in Rwanda, but that doesn't come with access to food, and that you know, people relied on their families in order to bring food, and so sometimes the food was not matching. And then even in your own journey, you started with, okay, let's bring food, until you realized with some of the patients that you had that the food you were preparing wasn't the right food. In a previous discussion we had, you talked about Rwanda having both universal access, but actually having a really high rate of universal access. I think you said something around 91%, 92%. And that the challenge with the government is that in order to have that high rate, they actually have to keep costs quite low, which means food security and nutrient security is kind of cut out of that provision. So you are really applying this missing link, but in order to get to where you were, you needed to build kind of a strategic and sustainable model of nutrition access. And that includes these public-private partnerships. Can you help us understand that a little bit more, how your public-private partnerships fit into, you know, that extra percentage that's needed for universal healthcare?
Yes, thank you so much. I think in Rwanda, we are really proud of that everybody can go to the hospital, and that's why the rate is so high with 91%. And it comes from 1994, after the genocide against the Tutsi. If you didn't have money, you couldn't go to the hospital. We had high rate of mortality from children, mothers, and all of that went really down because of that universal healthcare. So for us, we still have around 16% of the population that are covered 100% by the government. And then for the others, they're paying around $3 to $7 a year per person, which is really affordable. So one of the things is that putting money on top of that will then increase the premium. But also is that the data of saying this is the meals that need to be put into that, this is how much the meal will count, this is the different diet. So that's why for us, we took on the testing of the model and testing of the costs. To be able actually to work with the government. And one of the arguments we did to be able to have that public-private partnership is that, first of all, you will find that around the hospitals, you find restaurants that are run by for-profit entities that will sell a meal maybe from 85 cents to $1.5 to $2 for somebody who's earning less than $2 a day, which then become impossible for them. Then you have small boutiques. And for people that have been in Africa, there's like those big, we call them mandazi, it can be like a donut. Then you find mothers who are buying that for a few cents, give it to their children, the children feed their food, the mother is happy, but there's no nutrient in all of those meals. How can we work with the government? How can we work together to actually give a solution that can work? So our public-private partnership was signed last year. And the idea of that is that we duplicate the model that we have in our centralized kitchen. We put smaller kitchens in public hospitals so that food is available in the hospitals. Because also what COVID showed us was, even if we had the kitchen, the fact of moving the food came really was difficult, but also for families that had families that could bring the food, they were not public transport. So even with that, so that's why having kitchens in the hospitals is the way to go. So we are starting with the government with 3 hospitals that we are building right now that will be done in October. And then we have a plan for the next few years to actually expand in all 47 district hospitals so that it becomes a norm that when you are sick, you have food, and it's not that you have whatever food we're gonna give you, we will give you medically tailored meals to be able to speed up your recovery rate for you to be able to go back and be active in your society. And here, most of the time, if you're sick, you have somebody from your family. So you also have a caregiver. So it's not only one person that is missing to contribute to the community. It's actually two people that are not generating any income or revenue for themselves and for their family and for the country at large.
I'm so intrigued by this model because I think this is a quintessential kind of characteristic of social entrepreneurs like yourself, because you see the entire system, you see the entire value chain, and you say, oh, well, in order for my model to work here, I have to think about that, and I have to think about that.
Yes.
And so it's really interesting how you see the full picture. And so actually I wanted a deep dive into that a little bit more with the concept of the farm to fork. And I call it farm to fork and beyond, because you really are thinking about every single piece. Why is that important to consider the entire value chain? And what has been successful because of this approach? And then I know there's a few other social challenges that you're addressing almost as a byproduct of the nutrient security. So if you can touch on some of those, that would be amazing.
Yes. Our model just rely on one aspect, is that those medically tailored meals have to be affordable. One of the facts where people got into food security, one of the facts if you go in refugee camp, if you go in some of the public school, one of the facts where people are eating the same thing, one starch, beans, and sometimes vegetables, it's always about the costs. Those are the things that are affordable. So as what we wanted to prove is that, no, it is not. What is expensive is because the approach that is taken is actually expensive. So for us, the farm to fork is that we control the value chain. We are not entitled to all the fluctuation of the markets. And then the fact that we build that semi-automated, we are not heavily heavily depending on a lot of workers and manpower to have machines do part of it, of what we do, and then the dispatch. So all our model of the supply chain is actually to keep our meal down so that we don't actually decrease the quality of what we are giving to our patients. So that's why it is so important. And I think what we are doing then, we prove the model that we can produce a meal. Our meals at the kitchen, we produce them from 40 cents to 80 cents. But all our meals have a fruit, all our meals have something to drink, either milk or tea or a fresh juice. So you won't find a meal that has the same quality at the same price anywhere else here in Rwanda. So that's why for us it's really important. And once we have proven that model, once we have shown that actually you can have affordable meals, then our solution can work in any place where they do mass cooking, public schools, prisons, early childhood development centers, wherever you are cooking for a lot of people, we can help you. And in helping you, what we do is that to understand your cost drivers, to make sure that your kitchen is efficient and super efficient, because that's one of the things in our model. If your kitchen is not efficient, you can't produce efficiently. So that's why our kitchen is really the model, and we try to replicate that model. But also for us, it's open in the sense what we want to prove is that we don't have to continue doing what we used to do because it's okay. I think we have to do better. I think we have more non-communicable diseases that are really on the rise. We have more cancer, and all of that is linked to nutrition. Being in school, we have absenteeism, we had all of that. Food is really key to a healthy society. And I think food has been disregarded for a long time. And that's what we aim to do. And to be able to do that and actually change, we are also putting together what we call the Institute of Culinary Art and Nutrition. And the idea of that institute is, first of all, you can't change the way how people are eating if you don't change the way people are seeing food when they are cooking. So what we are doing is to give the nutrition knowledge to the people that are cooking. We are partnering with Drexel University to be able to do so, working in our curriculum. But with that, we're gonna keep most of the students, not most, half of the students ourselves, and then half of the students will be then given in hotels, in restaurants, so that we change how even the healthiest people, even the richest people are eating, because it's not because you have the means that you are eating well. Yes.
Oh, I love hearing your story every single time. We met before you were an Ashoka Fellow, and I knew it then, and it's just kind of reinforcing now. because you've talked about basically saying, hey, we're going to do farm to fork, but we also need to affect market dynamics so that we can do farm to fork affordably. And you're also saying, and we need to think about the actors in the entire food chain. So why don't we also train the next culinary cohort of chefs and cookers? I just love how fully connected your model is in order to provide nutrient access. I want to remind everyone that if you have a question, please feel free to put it in the chat. We have only a few more minutes, and I have a couple more questions, but definitely open to asking someone else's questions and not hogging all the questions to myself. I would love to go into something that you and I had talked about before, and this concept of food as love and food as part of cultural health. Your work isn't just about addressing nutrient access. You have the scientific backing for that. It is clear, and you've also created the model, but there's a culture piece to this, right? There's a love component to healing through preparation. What does it mean to heal through meals and meal provision and preparation? And how is that important for the context of the work that you do?
Yes. Yes, actually, yeah, food is love. And if you come to our kitchen, whoever can come to our kitchen, you have, like, it's written on the wall, food is love. Our program, actually, when we started and up until now, our program of the feeding, it's called Gemura. Gemura, it's a word in Kinyarwanda, which means bring food to. So you bring food to somebody that is sick, that won't be able to cook for themselves or even think about food. You bring food to somebody that just gave birth. You give food to somebody who lost somebody. You give food to party to a friend who just have their graduation. You go and bring them food. So food is a comforter. So food is love. And for us, that's the thing that was our way of going further, of saying it's not about whatever I'm going to give you. I'm going to put love into that process to make sure that whatever I'm giving you, it's even 100% or 150% more than what you need for you to heal. The other thing in our combination of food is love is the whole preparation. We have field officers in those hospitals. Though we are serving 1,500 patients, we know them, because there's also that appropriation of understanding. Because I'm giving you food, you might eat what I'm giving you, or sometimes you leave something, but I don't know that maybe you don't actually like this. You have already struggled. When in different diet, we have an alternative. So I can also give you that alternative. But if I don't know about it, then I'll make you eat things. And you have to know, everybody has been sick here. When you are sick, you don't really have an appetite. So one of the things also that we do is, how can we make sure to increase the appetite, to talk to the patient, to talk to the caregiver, because food is so important. So that's why for us, food is love. And for me personally, food is my love language. When I love somebody, I cook for them. That's my way of saying I care about you, I love you much, and I put all of that. And one day a friend of mine asked me, you should open a restaurant. And I said, I don't know if I can cook for strangers that much, because for me, all those patients are those strangers. We go to the hospital, we talk about their stories. And that's what, even growing as a team, we want to involve. Everybody has a time to go serve the meals. From the C-level to the cooker to the farmers, everybody goes there, because then you can really understand the impact and put a face in what you do, so that it's not generic. So we are trying to put love in everything that we do. It might be cliche, but it's a big motivation. It's a big motivation in our work.
I do not think it is cliche. I think it is amazing. I think the idea of love and food is kind of universally understood. My mother would absolutely agree with you, because she also shares her love through food and feeding people. So I love that element of your work. There are questions in there, so I'm going to give up access to you to some of the questions that are coming into the chat. And actually, the first one that I want to ask is, if you could magically wave a wand and transform the global food industry, what would be the biggest leverage point that you would want to try and change first?
I think it's first that we have to go back to food as food. I think there's so much processed food. I think there's so much duplicate, supplement, trying to actually replace the food because we don't take care of the food itself. So, and as long as we don't take care of the soil, we don't test our soil, we don't pay attention of what we give to the soil. I think just the premises of just in the food ancestry, let's go back to food as food.
Yeah. Food is food. Food is food. Yes. And it was interesting when you were speaking earlier about kind of the nutrient deficiency that occurs in very rich countries in the world, like the United States. So returning to food as access is really important. We have another question that asks, how does the business sustain itself? It's you have kind of this public-private partnership model. How does your funding get sustained?
Yes, we don't sustain, actually, we just subsidize a part because we are still feeding a lot of people that can't afford to have our meals. So as what we do is like, we call it a sliding scaling model. So meaning that for those, we have like companies that will pay for their employees, they will pay full price. If you go in those hospitals, the doctors, nurses would have access to those meals with their profit. And depending on which category the patient is, from those one that might not even be able to afford their universal health care that are subsidized by the government. So for those, they will receive the food for free. Some, if I'm producing a meal at 60 cents, some will receive it at 20 cents. What we wanted to avoid was to do the correlation of if you don't have money, you won't receive a great meal. Because in some places you find that the ones that they are offering free meals, the quality is like down. The ones that are paying have a better quality. So for us, you have the same quality, either you pay or you don't pay, so that we can subsidize. And then we rely heavily on philanthropy and partners and fundraising to be able to make it work. But for us, at the end of the day, what we think improving a model like that is, as we are documenting, as we are putting the recovery rate, we hope that the medical care insurance at one point having the means and having the data, because sometimes you don't even know how much does it cost to feed somebody. And that's what we are doing, is to collect those data so that in a few years you can present and say, this is actually how much it will cost you to feed somebody. And this is how much maybe if you put in the insurance, those can be done. But we are just at the beginning of this process.
And you're at the beginning, but you're also at the forefront of this process. So your work is amazing, and we've run out of time. Like I knew that this was gonna fly fast, but I can't believe we're already at the half-hour mark. So I want to thank everyone that's been with us today, and I want to share the words of a participant in the chat to you. So this is from Lori Walsh that says that I'll read it as her. I work in the areas as a medical doctor in Chicago on a hospital farm. I love hearing about your work that you're doing in Rwanda and how you frame food as love. I wanted to share that with you because I think the work that you're doing is absolutely amazing. You are bringing nutrients, you are bringing systems change, you are bringing economic development, you are bringing community, and you are bringing love to the healthcare system. And I think there's so much that everyone can learn from this work. So thank you so much for joining us today and for having this conversation.